here and what is our context, what do we do within the state. And then we're going to address rural and frontier health, and then health for formerly incarcerated populations in transition, minority health, and then we're also going to have some time at the end for ideas for moving forward. All right, so who are we? On your left-hand side, we essentially have the most important components of our grant. So what do? Essentially, what you need to know is all of our services are free. We serve the entire state, and what we care about is Wyoming consumers are well-informed, well-educated about their health coverage options, and then whatever they choose, we help them with that process. So that's what we do for our grant, but then as we know, there's so much more that goes into our work, and that's really why we're here, because as we do our work throughout the state, we encounter a lot of social determinants and a lot of barriers and a lot of instances where we need to go just beyond the health insurance application, and so that's why we're here having this discussion today. We also recognize there are a lot of other social determinants that we're not touching on. There's quite a few, and so we've just selected a few that we can give you some information on today. And then we also want to note that there is a lot of crossover with these social determinants, and what we oftentimes see is there can be a compounding effect on particular populations with regards to these social determinants. All right, so a highlight, just so you know, this is directly with regards to our work. Through the federally facilitated marketplace, we have 24,826 lives on our marketplace in Wyoming for this year. The good news is that's an increase by about 4.3%. And so that's a highlight. This is information of what counties have what enrollment, beginning with 2014 all the way up to 2017. And I apologize. I hope that you received the packet when you walked in. All this information is in your packet. You're welcome to take that with you. You can also just take pieces out of that if you like, and then leave the rest with us, whatever works best for you. All right, and so as we know, our beautiful state, and so now Monica will talk a little bit about, for instance, some stories that we've seen and some encounters we've had with regards to rural and frontier health.
Thanks, Heather. So I think I want to start out by giving what we interpret for the definition for rural and frontier. Some of the communities that we have, for example, in Laramie or in Cheyenne, we are closer to sort of urban areas, I would say. So Fort Collins is right up the way. If we needed to get to Denver to get to access to healthcare, plenty of referrals go down to Denver, and we can, there's primary care physicians within the community, there's specialists within the community. Those are what I would consider, we're rural just because by nature of being in Wyoming and the population and the amount of people per capita in our state is about 5.8 people per square mile. For the whole state. But then we also have some very, very frontier areas where they may not even have a primary care physician in the community. The closest one may be more than an hour and a half, maybe sometimes 2 hours away. There's also communities where even just getting an ambulance or a first responder out there is a hassle, especially during the winter months when there's snow on the ground. You pray you don't get sick in those areas. And so we want to highlight throughout this presentation, you know, this is very different than if you were growing up and have easy access to care in a city center. What does that look like? In our frontier population, there are a lot of seniors in that population. And they also are going to have higher health needs. I mean, they have more chronic disease the more you age, and so it's just more difficult to have sustained care. If they need to see a specialist, how it's more costly because you're talking about trying to get seniors transported. Maybe they're coming to Cheyenne, maybe they're coming to Laramie, or maybe they're going to Denver. Depending on which corner of the state you're in, we do send patients over to Salt Lake City. We go north up to Rapid City. And so those are that's a huge barrier within Wyoming at large is access to care, access to the care you need. And so I'm going to share a couple stories. One is out of Carbon County. So if you look at the map, if you're not familiar with Wyoming, Carbon is here down the southern part of the state, sort of in the center. Carbon County has an area called Saratoga. And there is a primary care provider there who is the only primary care provider within about 60 miles. So he sees everyone. He does hospice care, transition care from the hospital. He does primary care. Sometimes you'll find, or many times, most times when you go to a health center, they're not just doing traditional health and wellness. So you're going to have the social work aspect of it and referrals and access to food. Other panelists are going to talk about the housing situations. And so in Carbon County, one of the docs that come to mind can really appreciate, he spends a lot of his time even doing house calls. So I was mentioning that some people can't even get in to see the primary care provider. He will work extra hours to do house calls. That to me is going above and beyond. Some care providers don't have that luxury, especially if they're primary care and they're running their own clinic and they are the only person who's the provider. In Sweetwater County, if you move further west across the state, which is still down at the bottom, this population has one of the federally qualified health centers recently closed in that community. And so what I mean by federally qualified health center, they are going to be people, if you look into your packet there, there's a federal poverty level table. You're going to have people that are ranging between like 238% of the poverty level and below that typically can access care on a sliding fee scale. So they may not have health coverage, but they do have health needs, and so they can access care. This was a very, very, very big hit to the community. It was only open for about 3 years, and then trying to maintain a provider on site is the core reason why they closed. And that's another thing when we talk about rural healthcare in Wyoming. One of the most prevalent concerns is recruitment and retention for providers. So can we get someone to either, be born and raised here, practice in the community? Can we bring someone in the community? And then can we get them to stay? So at this time, they do not have a place where people who do not have health insurance can go and still access care on a sliding fee scale according to their financial constraints. The other population that I'd like to talk about is in Teton County, and we're just kind of giving you a tour around the state just so that you kind of have a glimpse of what does it look like with healthcare in Wyoming. Teton County is in the northwest part of the state. I would say in Teton County, a lot of people have heard of Jackson Hole. So in Jackson Hole, there is a clear division of, Clear division of financial capability. I'll just put it like that. So you're going to have people who are way above the 400%, and then you're going to have people who are living below 100%. With the minority population there is a Latina outreach center in Jackson Hole that partners with St. John's, which is the hospital there, to make sure that people have access to care. One of the things and you'll find within the minority population throughout the state is there is what we define as a mixed status family. So you're going to have people within the community who have kids that were born and raised in the States, and then there may be parents or grandparents that are raising them who may not be lawfully present. What has happened in terms of a barrier to the care is the children have they in theory have access to the care, and they can enroll in our children's health insurance programs, or they can enroll on the marketplace. But there's certain documentation that is required to be supported by the family that the family cannot provide. And so many times when we've been working with the immigrant population in Teton County and other counties throughout the state, the whole goal is to kind of come to Wyoming or come to the U.S. to provide more for the family. Yet some of the ways that is happening is actually creating a barrier and roadblock. I'm thinking of a particular case that we have in Laramie County where we are working with a family who, it is a mixed status family. Only the husband works in the household, and he has a child who is on the spectrum, a child who also has auditory impairment, and every year, we walk hand in hand with him to try to get his kids to maintain their Medicaid coverage because there's that documentation where they want the proof of income, and they will only accept proof of income if it is either employer statement or a pay stub. They don't accept attestations and things like that. And so that has become a barrier because if his kids do not maintain the coverage that they have, it will be a financial strain on the family, and then they really, we're talking about outcomes, the ability to continue school and be successful citizens within the community. So those are just a bit of the stories that we have around the state. Heather's going to share a quick Department of Corrections story, and then we'll dig down into some of the specific topic areas that she mentioned.
Okay. Thank you, Monica. And so in your packets that you have a state map, which I think will be a little bit easier for you to see. We don't have it on the slides. But this is from the Wyoming Department of Corrections, and what you're seeing on here is where our prison facilities are located, where there are centers when people are entering back into their communities, and also where we have our adult community correction centers. And so Enroll Wyoming has served consumers in all of these areas, which is very powerful to get the stories from the different locations and where incarcerated individuals are encountering barriers and what they're going through with regards to access and their health coverage once they transition out. One thing that we're experiencing quite a bit in Wyoming is thus far we have not expanded Medicaid in Wyoming. And so, for instance, if an individual transitions back into their community, say, in February, they have a better chance of meeting that 100% of the federal poverty level to be eligible to receive that assistance if they go through the federal marketplace. But if they're transitioning back into their community, say, in October, between October and November, they're expected to make that 100% of the federal poverty level. So if that's for one person, $11,880. And so that itself is a barrier because it's substantially difficult to make that much money in that short amount of time. So we're looking at what time are you transitioning, because that's going to have an impact on what we're able to do and how we're able to serve you with your healthcare needs. And so that's something that we've encountered. And Wendy will go into quite a bit more with regards to this population. But we are also serving individuals at the transitional centers, the adult community corrections. And so one thing that we've seen in Wyoming as well is Gillette for quite some time was very popular. Gillette is over here in Campbell County. And, yeah, right, sorry. Gillette is in Campbell County. And what we're seeing there is for quite some time, individuals wanted to transition into Gillette because of the ability to enter into the workforce very easily. But now we've seen a downturn in that community, so that's putting more strain on the Casper and the community transitional centers because people are maybe not wanting to go to Gillette as much. Also, when we're doing applications prior to the transition, people need to put down where they're going to be residing, and lots of times when they're in transition, they do not know which center they're going to land in either. So that's another barrier and something we're experiencing with that population. All right, so you guys know that Wyoming is rural and frontier. Here's some data. This is what we're pulling from CMS, Centers for Medicare and Medicaid Services. And we have 79% of our individuals on our marketplace are in rural zip codes. We talked, the keynote speaker on Wednesday night spoke about zip code means a lot when you're looking at how your health care and how healthy you're going to be and kind of some of those social determinants. And so in Wyoming, we actually have the largest population representative of any other state that is on the marketplace in a rural zip code. All right, and so now we're going to delve in. Catherine's going to be speaking about our rural and frontier health, but to set the stage for this, this is a personal story from Pine Bluffs, Wyoming. That's in Laramie County, down in the southeast corner. Rebecca lives in Pine Bluffs, but her and her spouse work in Cheyenne. And so even though, as you can see from her story up here, even though they do now have a health center in her community, when she works in Cheyenne, she works business hours, and her health center is only open during business hours. And so even though the health center is literally just down the road from her, she cannot access her services there because of the timing. And so that's something that's really set up a barrier for her. And we know that this is something that a lot of citizens in Wyoming are encountering because we have a lot of people commuting to one community to work and then living in another community. So I will turn it over to Catherine.
Hello. I'm Director of Nursing at the Cheyenne-Laramie County Health Department, and in our agency, we try to meet the needs of people who live throughout the whole county. It's not just in Cheyenne. And in doing so, we do a lot of outreach programs. Everybody thinks of public health and they think flu shots or immunizations, but we're much more than just that. And we case manage people who are coming onto into Laramie County who are HIV positive through the Ryan White program. We manage them to make sure that they're receiving medications, keeping their viral levels low so that they are not communicable disease problems. We also have the communicable disease program that we, of course, do TB investigations and case management with positive TB clients, and we do our own disease investigation in Laramie County, so if there is a reportable disease, we follow that and make sure that we contain that, prevent it from spreading. And I guess one of the main things that we do is with our maternal child health program. In that program, we go to throughout the county and again providing that outreach, but public health, we're the boots in the trenches. We're the ones that are in the homes of the clients. We have relationships with our clients. We're in their homes so that we can see what's going on. We see if we can see some of the drug paraphernalia, what their habits are by building those relationships, and through that, we are able then to find out the resources that these people may need because we have these close-knit relationships with these people. So with this, we have the FQHC, the Federally Qualified Healthcare Centers, throughout our county. And in Pine Bluffs, like she had mentioned, we do have the UW Family Practice Clinic, and we have one in Cheyenne, and we have the HealthWorks in Cheyenne. We also have Crossroads, which is a clinic for the homeless people. They also see 25% of non-homeless residents. So, and that's in our facility. So we have these places, but the problem is they're not meeting the needs. They're not being opened within the hours that they need to be, so that the people who we try to, we encourage people to go to school, we encourage them to go to work, but if they don't have a physician's office or a primary care provider that they can go to after work or before work, that becomes a problem. So for access to health care, we want to increase that. And that is something that just recently, because there are more people I think are using the FQHC facilities, the HealthWorks, I just learned yesterday, is now 3 weeks out. So that's not effective. So we need to see what we can do with that. Public health will work with the primary providers and see how we can help each other through these times. The big thing for us, I guess, with public health is the outreach, because they don't go to the facilities. It's difficult for them. So we're going to the schools, we're going into to do some testing, screening, vaccinating, providing education, schools, work, places. So our outreach efforts, I think, are what we really need to focus on to help try and break down some of these barriers. The other problem is the transportation, because even if we find the expertise, the people who have the experts, the specialists, they may be in another county, or they may, for Laramie County, a lot of them are in Colorado at the Children's Hospital. Some of the insurances, it doesn't work because they are outside of their network. So even if they have insurance, it's still, we have to figure out how to meet those needs, how we're going to find a way for them to travel back and forth. And through different programs, we're able to get some of those resources and try to meet the needs of those clients.
Okay, Thank you, Catherine. And just to tag on to that a little bit with regards to the transportation, even when people are living or residing within the maybe the city center like Cheyenne, which is a city in Wyoming, it's one of the largest. Depending on where they live, so what part of town they live in, determines their access to transportation. And so we will have communities that are accessing a lot of services within the community, but the transportation system within that area is so low and serving the community so poorly that oftentimes they will maybe schedule an appointment, but they will show up to that appointment late because of the transportation system. And so the interconnectedness within these, again, is so very important. All right, so now we will have a personal story. This personal story comes from Casper, Wyoming. This individual's name is Daniel Upton. After being released from incarceration, Daniel completed his 2-year degree at Casper College in 2014. He is now the social recreation coordinator at the Boys and Girls Club of Central Wyoming. And so,
good morning, everyone.
let's try this one.
Good morning, everyone. My name is Daniel Upton. I'm the social recreation coordinator at the Boys and Girls Club of Central Wyoming, and I've worked here over 1.5 years. Before that, I was released from the prison system several years ago. The main identifying factor about my transition from the system to the streets probably centers around the lack of communication about options for inmates that were getting out. I believe that they did tell us a little bit, and as I made the transition into the workforce, I became the owner of a landscaping company, and I went on the website that is designed to give access to through the Affordable Care Act. However, there were so many problems with the website at the time that I couldn't avail myself of that system. So, long story short, I didn't have any health care for at least the first 1.5 years that I was out, mainly because I didn't know where to get it. I didn't know who to talk to about it, and so I just kind of let it slip by the side. I was pretty healthy and busy working hard, so I believe that the information that would help others make the transition more smoothly is just some maybe clear communications about options for those who are making the transition. Hopefully this information has been helpful for your discussion, and have a great day.
I apologize, I didn't realize the video wasn't showing. So that's Daniel and his story. Again, as you heard, when he was transitioning, that was when the marketplaces were just coming up and running. So his experience with regards to accessing the coverage looks a little bit different, fortunately, than it does now with regards to the federally facilitated marketplace. The web-based application is far better than it was in the first year with Daniel's experience. We did reach out to the Wyoming Department of Corrections, and as you can see up here, which I will let you read it, we have a statement from Miss Christy Weiler. Essentially, the most important thing to take from her statement is, even though individuals, when they're transitioning from incarceration, they have that 60-day window, which is a special enrollment period, to find health coverage, there's so much for those individuals to take care of within that time frame that oftentimes accessing the health insurance maybe goes by the wayside or simply just does not get done because there's so much on an individual's plate, like maintaining residence, finding employment, if they are planning to attend higher education or completing their GED, family. And so there's a lot of components that go into that transition period that the 60 days simply is not enough time to really be able to get everything set. And additionally with that, again, it depends really on what time of year that you're transitioning in Wyoming, since we did not expand Medicaid. All right, and so now Wendy will talk to us about some of her experiences with regards to this population. Wendy is in Sheridan, but she has some stories from all over. Okay.
My name is Wendy Ongro. I'm a physician assistant, and I specialize in marginalized populations, which are folks who are experiencing homelessness in and out of correctional facilities. I have worked as a medical provider both at the state correctional level, at the county correctional level, and through Healthcare for the Homeless, I worked extensively with the Casper Reentry Center and many of the inmates there. People are very interesting in that we as medical providers, we're very medical centered, and that's just not how people operate. Folks are going to prioritize housing, transportation, employment before they even consider their health care needs. And then if they don't get their psychiatric needs addressed, it's going to be even harder for them to address their medical needs. One of the challenges as a medical provider is that our industry is very myopic, and we don't want to look past those medical issues. But if you don't see what's going on with the individual, you might have a really poor health outcome. For example, when I was the medical director at Healthcare for the Homeless, we were able to leverage $5,000 to $6,000 worth of medical care for a gentleman who was living in his car, who subsequently froze to death a few weeks later. That is an epic fail. And as a result of that experience, I really start to talk to people about their housing situations. I've become a housing first proponent. And part of the handouts that they've provided you talk about some of the data showing how important housing is to the overall well-being and health of the people that we take care of. That is on such a major timeline for folks who are re-entering the community from the correctional system, that they often miss that 60-day window for getting enrolled in health insurance. The other piece is that a lot of them are very leery of the health system, and so until it's an absolute crisis, they won't come in. That's the other take-home that I have for medical providers, is that you want to be sensitive to what's going on socially to those clients that you're working with, because that medical condition may be what drives them in and gives you the opportunity for the first time to provide that very paranoid person that psychiatric and social support that they need. That might be how you establish the rapport that over visit after visit after visit turns into the case management, the housing stability that that person needs to have a better life. And that gets lost a lot in those 7-minute appointments, which I don't do 7-minute appointments. So those are some of the issues that we see with folks. Practicing medicine the way I do requires a great deal of collaboration, not just with the other employees, the nursing staff, the social workers in my practice, but also with the other organizations in the community, such as the community mental health centers, the parole officers, police departments, different social agencies, Department of Family Services, Department of Health. If you can't integrate and supplement your own services with the others provided in the community, your patient doesn't get everything that they need to be healthy.
Okay, thanks, Wendy. And a couple of other notes with regards to Medicaid. And so each state gets to administer their program within maybe certain bounds per federal guidelines. But one thing that we are doing here in Wyoming, which could also be creating a barrier, is if an individual is receiving Medicaid to cover their health care needs prior to incarceration, when they become incarcerated, their application essentially is done. So instead of just putting it on hold, that application and that individual's coverage is completely stopped. And so when people are transitioning back into the communities, instead of being able to go back in and say, just bring my application back up, they have to start the entire process again. And so that's another barrier that we're seeing that's, again, just another impact and something that we're seeing with that population.
Can I add to that, Heather?
Yeah.
Many states that did expand Medicaid, they actually enroll their inmates while, you can't have Medicaid cover an inmate. It's illegal at the federal level. But what a lot of expansion states do is they enroll that inmate while they're in the correctional facility, and then they suspend that enrollment so that the day they hit the door, their health care is already taken care of. The other thing is that you were talking about the 100% federal poverty level. A lot of people really can't wrap their mind about that. If I have an individual who comes in and say they're a single person making $800 a month, I cannot get them any assistance with health care, health insurance. I cannot get them on health insurance. If they make $950 a month, I can enroll them on the exchanges, often for $15 to $35 a month with a $1,500 deductible. I don't know if that makes any sense, but that means the less money you make, the less help you're able to get, because that group that was making $800 a month was supposed to be enrolled on Medicaid, and we chose not to take it.
Yes, thank you. And we're seeing that quite a bit. And that's something that within our roles as healthcare navigators, when we're experiencing these consumers and these patients all across the state, we know that maybe going through the marketplace is not an option because it is going to be too expensive because you are in this gap. But what else can we take care of? So can we help you locate a health center, a health provider in your area that will assist you and will do a sliding scale fee? Can we assist you with maybe signing up for food, or what else can we do for your family? And oftentimes with that as well, we also look at, you have a family and then you have a child. And so who can we take care of, and what can we do with this entire family? So what might be the case for one family member might not be the case for another family member. And our work is very individualized, and it must be, so that we can serve and do the best we can to better serve our Wyoming citizens in that capacity. Okay, thanks, Wendy.
Thank you.
All right, and so now we will hear Angie's story, and I'm going to try to do this better this time so that you actually get to see the entire video. I apologize. All right, and so this is Angie. She lives in Cheyenne, Wyoming, which is in Laramie County.
Yes, it is. Okay, I can edit that. Okay. I'm going to do both because I'm not sure which format is going to be better.
Okay, works perfect.
Okay, but this camera might be fuzzy because I'm moving. Hi.
Hello.
Thank you for coming.
Oh, thank you so much for having me. I appreciate it.
So we wanted to talk with you about the importance of obtaining health care and having health care in Wyoming.
Okay.
So one of the things that we would like to ask you is, do you feel that, if you could introduce yourself, that'd be great, and then describe a time where you have barriers in accessing your health care.
Okay. My name is Angie Ingram, and I am a Cheyenne resident. And having access to healthcare, there is a barrier, especially with me. I work 2.5, 3 jobs at any given time, so I'm constantly working in order to stay above what I need to get in order to, because I'm right there on the line when it comes to that gap, if that makes any sense.
The Medicaid gap?
Yes, the Medicaid gap. So in order to be on that line, I have to constantly work in order to provide for my family. There is a barrier, however, when it comes to that affordable health care, is if I do get sick, if I need to take a day off, I have to do that juggling in order to make sure that everything's okay in both household as well as financial, and I have to juggle a lot, and it gets quite crazy.
So I understand that you do have health insurance.
Yes.
Through one of your jobs.
Yeah, actually, yeah, through my one jobs. That's correct. Yes.
Okay. You can correct me if I'm wrong.
Okay.
But what are some challenges to seeing your primary care provider or your family doctor, either for you or your children?
Oh gosh. Considering one of my jobs, I do travel, and it's very hard to be able, because my doctor only has a certain time frame in which she can see her patients for whatever reason. If I am out of the city for that reason, I can't see her during that time, and I would have to go to another physician and give all my history again and be able to say, okay, this is what's wrong with me, and this is what needs to be fixed. And then they could either say, oh, okay, and then just go against what she wanting to do because she has a health plan guide for me, and they're like, no, we want to do this, and then all of a sudden I'm taking 15, 20 medications that I really don't need to take, and then I end up getting sicker, and then we go back into that horrible round robin type of thing. So it is extremely hard and something that is extremely frustrating for anyone that is like me, or anyone that falls into that area that I fall into, and works the way I work in order to survive. So
Wonderful.
So
Thank you for your input. I appreciate it.
Thank you.
Heather, I'm going to jump in for a second. So Angie, when she's talking about being on the line, so when you look at that federal poverty level table for an individual, that's $11,880. I think when we sat down about 3 different appointments to work with Angie, I believe she is making maybe $60 to $150. That actually puts her at 11,800, or what, for a household size of 3. I forget what it is for a household size of 3. So when she's talking about if I'm sick, I have to make a choice, that's very real. If she misses days because she does not get that paid time off for any of the jobs that she has right now, she's going to fall below the line, and then she'll have to deal with the tax man at the end of the year because she wouldn't have qualified to be on the marketplace in the first place. And so that is something that when we are talking with, it's minority groups, but it's a lot of the groups that we work with in the state of Wyoming, we've sat down with people and we've actually budgeted out. I remember working in Newcastle, which is in Weston County, and a lady was down to $34 left. Her health plan cost $34. Her choice was to try to find somebody to carpool to work so that she could save the gas money, reduce her grocery bill, rob Peter to pay Paul, which means basically choose to pay a light bill late or pay for rent, or go back and try to get her employer to give her a raise, which she tried to do multiple times before. And so that's a very, very real conversation. She did hold employment, and it was a choice that she made. That woman walked away without health care and said, I'm going to risk it. That's something that we deal with very, very, very frequently. And I know Heather can share a story of a lady in Gillette who had breast cancer and was trying to make a choice.
We had a similar example at the Sheridan Health Center. We were a pilot program for at-home colorectal cancer screening, and we saw a 30% jump in patients who are willing to be screened. First of all, because nobody wants a colonoscopy, but the bigger reason was that the day of prep and the day of colonoscopy are 2 paid days of work that our patients would have had to go without if they wanted to complete that screening. Whereas with the at-home test, they can do it at home when they have time.
Thank you, ladies. All right, and so now we will move into, and I apologize, this is going to be a correction from what's on the screen as well as in your slides. So to speak just a little bit on minority health and what we're seeing in Wyoming, we have Charles, who is a patient advocate at Sage West Health Center in Riverton and Lander, and that's in Fremont County, which is in smack dab really in the center of our state. So, Charles?
Hello, my name is Charles Ergen. I'm a patient advocate at Sage West Healthcare, both Riverton and Lander. I'm a member of the Eastern Shoshone tribe on the Wind River Reservation. The Wind River Reservation, if you don't know, has 2 different tribes on it, the Northern Arapaho members and the Eastern Shoshone, and it's pretty much a large portion of Fremont County. And so when we're talking about, access to healthcare, we're talking about 2 different cultures just trying to live among one another. They're trying to live with these 2 different cultures and trying to get an understanding of one another. For example, with the Native American tribe, it's kind of hard to get an understanding of, a lot of people think, well, it's just this way or it's this way. But with the Native population, due to, we live in 2 different cultures. For example, when it comes to religion, with the introduction of boarding schools and whatnot, Catholic way and stuff was introduced to the Native population, but they still also had the traditional way. And so some families have actually converted to like Catholics or Episcopalian or some denomination. Some families went back to traditional ways and that's all they practiced. But what a lot of families have done on the reservation is found a way to combine both, being able to use both Catholic and traditional without taking away from either one. And medicine's often looked at the same way, where you take Western medicine and then you take traditional medicine, being able to combine to use both of them. And so just trying to get people to understand a lot of that. And with the people on the reservation, you can't just heal somebody only physically, you know. There's 4 parts to a person. There's a physical part, mental part, emotional part, spiritual part. You can't affect one without affecting all the others. For example, like diabetes, you know, once somebody gets diabetes, the physical part gets affected, but not only that, but the emotional, you know, the mental, the spiritual part, you know, why me, kinds of things. And so, you know, there's always that conflict. My job was actually created to kind of help ease the tension. You know, it's not really a big secret that the city of Riverton and the reservation have never really seen eye to eye. And so, you know, there's been a lot of things in the news and whatnot. And so when it comes to access of health care, the Native population kind of have this dual citizenship, you know, where it's not just one or it's the other. You know, not only is the Native population, you know, a tribal member, but they're also, you know, a citizen of the city of Riverton, of the county, of the state, and of, you know, the U.S. But a lot of times, they often get the choice of, well, you're either a reservation person or you're a member of the county. It's either or, you don't get both. And so there's always that disconnect that they always see. And so with that, it kind of breaks down the trust a little bit between the healthcare system and the people from the reservation. And sometimes there could be just really simple fixes. We had a temporary doctor we had a doctor in the hospital once, and he came and grabbed me. He says, "Come on, we're going to go talk to this family and whatnot." And so he came and grabbed me, and he says, "You know, this person has a lot of alcohol issues." And so he says, "But don't worry, we got this, we got this. Oh, by the way, the family's mad." So what's the family mad about? They're mad about being in Riverton Hospital. That's it. Okay, you know, like as I said, they don't often see eye to eye. So we went into the room, and the first thing he did was he sat down and he was eye level with everybody. And he turned to the family, and he was right, the family was mad. He turned to the family, and the family says, you know what this person needs? This person needs a spiritual awakening. Family got real quiet. And he goes, this person needs to heal physically, mentally, emotionally, spiritually. Okay. He says, don't worry about the physical part. That part is mine. What I can't do is I can't help them mentally, emotionally, spiritually. Okay, so I'm going to put that back onto you, onto the family. I want you to go out and get whoever you turn to spiritually. I want you to bring them here into the hospital and do whatever ceremony that you need to. Okay, that's going to help them spiritually. Okay, in turn, that's also going to help them mentally and then emotionally. And we have all 4 bases covered. Okay, it took exactly 5 minutes for him to sit down with the family and do that. Completely changed the family's attitude about being in Riverton Hospital. You know, so simple little things just to try to help get a better understanding. Currently, there's about 10,000 enrolled Northern Arapaho members and 43 enrolled Eastern Shoshone members, and then we have 2 clinics. And so there's a housing shortage, so we have a lot of people living under one house. You know, if you used to ask how many people live under one house, you may get the answer, we have 10, 12, 15 people living under one roof. And so they may only have 1 or 2 vehicles. So if you're not on that vehicle when it leaves at 8 o'clock in the morning to take everybody to work, you're stuck at home. And the nearest healthcare facility could be 20, 30, 40 miles away. Okay? And there's not a whole lot of public transportation out in Fremont County. So a lot of times, you know, that there goes your access to healthcare. You're stuck at home, you're watching the kids, you have to take care of everybody else, you know. And so, let's see where I'm at. So some of the tribes have actually kind of pulled together different ideas of what to do to increase that access of health care. One of them was the Northern Arapaho tribe has actually pulled together some money, set aside some funds, and say, okay, this part is going to be available for to help pay premiums for anybody who has chronic conditions. Okay, and so you sign up for this, they get onto the Hicks Blue Cross Blue Shield. That allows them to go seek health care in their closest facility. As I said, there's a huge housing shortage, so a lot of people from the reservation have moved to the closest towns, Riverton, Lander. But if you don't have any insurance, you don't have access to any of that. And regarding other things like the homeless population, you know, we've created new programs as a collaboration with people from the reservation and the people from the city of Riverton and the people from the city of Lander have got together, formed a board. You know, we've created things like Eagles Hope, where it's a transition place. It's not run by any particular program. The only way we get incoming money is by people who pay rent there. You know, it's a lot affordable than any other place in town. You know, you get a room for about $350 a month. And sometimes we use other programs to try to help get them in, like First Stop Help Center, the PATH grant, and things like that, to help pay for that first month's rent. And then we've also started other programs on the reservation to try to create a more healthier environment. For example, the Eastern Shoshone tribe has actually started a CrossFit program, which they were not the first reservation in the United States, but one of the first people on the reservation to get CrossFit and to incorporate that, but to also not only incorporate the exercise portion, but also the nutrition portion through a 10-week program they call Lifestyle Balance. And so, and you know, Wendy's right, 7 minutes isn't enough to see a person and to try to help with all these different issues of what's going on. So, you know, and the smallest changes can lead to, or the smallest things that we can do as healthcare providers can make huge changes. I'll just finish off with a positive story of, I got called one time, says, you know, somebody wants to see you in the OB unit. It's like, okay. So I went and seen this patient, and, you know, they were like, are you Charles? And I'm like, yeah. And have I met you before? No, you've never met me before. But I've heard of you. It's like, okay, and this is getting a little weird now, but, and I said, okay. And they said, you actually sat down and talked with a friend of mine. I was like, okay. And they said she had like huge alcohol issues. You know, she was drinking constantly every day for like 2 months. And she had this huge addiction, and you just sat down and you talked with her, and you talked about things and things that she was going through in her lives, you know, all the stress and grief. Grief is huge on the reservation of people that she's lost. And you provided her with a little medicine bag of cedar. You know, cedar is some of the things that we use as traditional medicine. And you said a prayer with her. And if you ever work in a hospital setting, you see a lot of patients, but you never see any after effects of what happens to them. And she goes, you know, she's doing good. She's been 6 months sober, and she's been on the right path. She's got her kids back. She's got a job. She's got her own place to live. And she wanted me to tell you this. And then she goes, and then, you know, I also need help. So I'm just wondering if you can help me out too. So I just wanted to kind of end on a positive note. That was her story. So thank you.
Thank you, Charles. Some very good stories. All right. And so now we have just an announcement actually for something that we're doing in April with regards to Minority Health Month. And so Monica will just make this announcement for us really quick.
It's going to be really quick. In order to address more sort of the health inequities that our community faces, we are putting on a Culture Fest promoting health and justice that will be held in Cheyenne on Saturday, April 29th from 10 a.m. to 4 p.m. People can come. There's going to be a celebration of the various cultures that are represented, but also there'll be free services and access to care. And our hope there is to, while we have people in the room, try to meet a need instead of handing them a flyer and saying, this is where you can find me. There'll be medical providers on staff. There will be lawyers on staff to talk about some of the maybe landowner tenants' rights and things like that with people. And so if you have an interest or just curiosity, we welcome you to visit Enroll Wyoming's Facebook page. You'll see more details about what's going to happen that day. And then come on over to Cheyenne if you are local, more local, to have some fun with us. Thanks.
Yep. And with this is definitely an effort to, again, take another step outside of maybe the health silo or the healthcare silo. There's so many more components, and so that's what we're doing later this month. And so now we really just scheduled some time. We have about 8 minutes or so. We want to hear from you, maybe stories or questions or ideas you have, either for myself or Monica, or certainly for the panelists, because we greatly appreciate their time and their expertise to come and share with us. And to kind of prompt this a little bit, we have a couple quotes up here for you. One of them is from Wendy, actually, earlier this week, and we thought it was really good, so we put it on the slides. It says, challenge providers to look outside medical paradigm. And so this is very much what we're talking about. There's so much more that goes into a human being and into their health care and what it really means to take care for them and provide good care. And then we cannot ignore our pain and feel compassion for it at the same time. And so those are a couple just kind of starting off quotes to hopefully wrap everything up. We have some stories that we can share, but I'd actually like to open it up to see if you have questions, particularly, you know, something as a topic area or something we highlighted on or an area of the state really resonated with you. So it's open to you. We can talk at you some more, but we'd like to hear from you guys. Yeah.
This is directed at, I'm sorry, I forgot your name. This is directed to the gentleman at the end.
Oh, yeah.
So you said you take care of, you're the provider you worked with, wanted to take care of the patient physically, mentally, spiritually, and emotionally. This is not real. A lot of what we talked about today is medicine in the clinic, but I'm wondering what about more in the EMS setting? Because that's what I do. I'm a volunteer EMT. I spend a lot of time in the back of the ambulance with patients. How can I incorporate that more is my question. And not specifically to you, actually, but more the panel in general.
Great question.
I think one thing is maybe asking the patient what their religious or spiritual background is, because a lot of times when people are, especially if they're conscious, I mean, if they're in acute distress, you can't do that. But having an idea of, a lot of times when people are having that health crisis, they're also having a spiritual crisis because they're hitting their mortality face first. And so having an understanding of, you know, I'm a practicing Catholic, I'm a practicing Episcopalian, having some idea of what that means for them in terms of their spiritual paradigm can be really helpful, because you can help them pull on that religious background to help them calm down and find some peace and comfort in the experience that they're having, to provide that experience with some meaning.
And I understand that sometimes in medical emergencies, you know, you're always going to have to make adjustments and whatnot. A lot of, especially Native Americans, will carry like medicine bags as a necklace and whatnot. So being able to make sure that that is taken care of properly, you know, it's not ripped off or anything, because that's actually a part of them. They may actually, or the family may actually want something brought with them, you know, to help protect them in that manner. Also, just like I said, simple little things will make huge differences. You may, you know, ask, or just think about, you know, does somebody need to go with them? You know, do you have to make that extra little room, maybe an ambulance, or maybe they need to use your phone to call a relative to try to get to the hospital, and then just making sure that, you know, with elders are held in very high respect, so making sure that they're taken care of also, because, you know, check on everybody in the house. As I said, there may be a lot of individuals living in that household, so.
And I worked in the emergency room for 11 years, and also I was a volunteer firefighter and EMT, so when I would ride in the bus in the back with someone, it is hard to look, you know, because you're so focused on the injury, it's hard to look past that and think about their emotions, because you just think, I've got to stabilize this person, you know, you're focused on that. But even with just listening to this, I think you're going to have a better awareness next time. You're going to be really kind of watching their emotions and being more attentive to that. If I know that I've had clients that have asked if I would pray with them in both settings, and you know, feeling comfortable with doing that, letting them lead, so because you don't know what their religion is or what their beliefs are, just letting them do that, but be supportive of them while you're there means a lot. I mean, it decreases the stress, which, you know, decreases further injury. It increases their oxygenation, you know. So it is beneficial, and just with you asking that, that's awesome.
Yeah.
And that can be with anybody. It doesn't have to be with a specific certain population, you know. When you go to anybody's house, you know, think of it. I know I need to take care of them physically, but how about mentally, emotionally, and spiritually? So.
Great question. Thank you.
And during my visits, I like to measure, am I talking too much? Because if I'm talking 2/3 of the visit, I'm not doing my job right. I need to shut up and listen to what the patient has to say.
Thank you very much.
Thank you.
Any other questions? Yes, ma'am.
Yeah.
A question for Wendy. Wendy, you talked a little bit about transitioning folks coming out that are incarcerated. I'm wondering, when a person leaves jail or the penitentiary or whatever their incarceration situation is, are they given any term of medications, a month's supply, 2 months supply? The enrollment period is, 2 months, so they have 2 months to enroll or try to enroll in the Affordable Care Act or access. But do they have any means to manage that interim coming out of incarceration?
They receive nothing. And in fact, there's a case through our clinic where we had a gentleman who was insulin dependent, and 3 months after he was out, his parole officer finally put his foot down and said, you need to go to the clinic. And so I saw the gentleman. He wasn't the most compliant. The parole officer and I kind of rode herd on him. When we first got him, his hemoglobin A1C was 12, which is extremely high. But by working with him, playing the long game, you have to play a long game with these patients. You're not going to see them once and get them fixed. You're going to get them fixed over 2 to 3 years. That's the timeline you have to have in mind as a medical provider. This was a great success story because by May, we started seeing him in December. By May, his A1C was down to 6.5. But yeah, literally when you come out of the correctional facility, you have the clothes on your back. That is it.
Thank you. Great question as well. Any other questions or comments? All right. So we are at our time. So thank you very much to the panelists.
Thank you guys for being here.
And thank you very much for joining us again. You're welcome to take the entire packet with you. If you, again, just want to take pieces out, that's perfectly fine. We will reuse it. We do a lot of presentations. And then we also have our contact information up here if you choose not to take the slide presentation with you. So thank you for joining us.